This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Journal of Neurosurgical Sciences, published in 2026. It's a systematic review and meta-analysis titled Rapid versus Gradual Weaning of External Ventricular Drains in Aneurysmal Subarachnoid Hemorrhage.
This is a topic that hits home for anyone who has spent time in the neuro ICU. We deal with aneurysmal subarachnoid hemorrhage, or ASAH, on a daily basis, and a significant portion of these patients require an external ventricular drain, or EVD, to manage acute hydrocephalus or intracranial pressure. But the million-dollar question has always been, once the patient stabilizes, how do we get that drain out?
Exactly. It's one of those clinical decisions where if you ask 3 different attendings, you might get 3 different protocols. Some prefer the gradual wean, where you slowly increase the height of the pressure scale over several days, and others prefer the rapid wean, where you move straight to a challenge and then pull the drain.
And that's why this 2026 meta-analysis is so timely. The authors pointed out that while EVD insertion is common, the effect of rapid versus gradual weaning on specific measurable outcomes has been historically debated. Ilara, walk us through the primary aims of this systematic review.
Of course. The research team aimed to compare these 2 strategies, rapid and gradual weaning, by looking at 3 critical endpoints: infection rates, total hospital stay, and the requirement for a permanent ventriculoperitoneal shunt, or VPS. They really wanted to see if one method superiorly reduced the long-term dependency on CSF diversion.
Let's start with the VPS requirement. For the residents listening, this is a major concern. If we wean too fast, do we fail the patient and force them into a permanent shunt? Or does the gradual wean actually train the arachnoid granulations to work again? What did the meta-analysis find?
Interestingly, when looking at the pooled data, the study found that the weaning strategy, whether rapid or gradual, did not show a statistically significant difference in the requirement for a ventriculoperitoneal shunt.
That's a powerful point. It suggests that the need for a permanent shunt might be more dependent on the initial grade of the hemorrhage and the volume of blood in the ventricles, rather than how we manipulate the EVD dial at the bedside.
Precisely. And moving to the next measurable outcome, infection rates. We know that the longer an EVD stays in, the higher the risk of ventriculitis. The paper analyzed whether the duration of the weaning process itself impacted those infection numbers.
I would imagine that the rapid wean would have a slight edge there, simply because the drain comes out sooner.
You're spot on. The systematic review highlighted that a more efficient weaning process, specifically the rapid weaning strategy, can lead to a decrease in the total number of days the EVD is in place, which logically correlates with the risk profile for EVD-related infections. But even more striking was the impact on the hospital stay.
Tell us about the hospital stay. In the current era of neurosurgery, efficiency and bed management are vital, provided they don't compromise patient safety.
The meta-analysis found that rapid weaning significantly shortened the length of the hospital stay. By bypassing the multi-day process of incrementally raising the drain, patients were able to be cleared for discharge or transferred to rehabilitation much faster.
So if the rate of VPS insertion is essentially the same, but the rapid wean gets the patient out of the hospital sooner and potentially lowers the infection window, that makes a very strong case for the rapid approach.
It does. However, the study also notes that measurable outcomes are key. While the meta-analysis provides a high-level view, individual patient factors still play a role. But as a general institutional protocol, the evidence here leans heavily toward the efficiency of a rapid wean.
This is great for our residents to hear. When you're on a night shift and you're wondering why we are still stepping up a drain by 5 centimeters every 24 hours, you can look at this 2026 data. The systematic review suggests that we might be extending the hospital stay without actually reducing the need for a permanent shunt.
Exactly. The paper really clarifies that the gradual approach doesn't necessarily offer the protection against the VPS that many traditionally thought it did.
It's about moving toward evidence-based weaning rather than tradition-based weaning. This meta-analysis in the Journal of Neurosurgical Sciences gives us a clear framework to reevaluate our ICU protocols for ASAH.
Well, that's our 5 minutes for today. A big thank you to the authors of this study for providing some much-needed clarity on EVD management.
And thank you all for listening. We'll be back next week with more updates from the cutting edge of neurosurgery. I'm Dr. Aris.
And I'm Dr. Alara. We'll see you next time on the Neurosurgery Hub.